I just want to thank everyone for joining this morning. I know it is early for some of you on the West Coast, and just thank you for joining the call. And my name is Angela Antilla, and I will be presenting today on the Resident Impact and Facility Capacity Surveillance Reporting Pathway for the Long-Term Care Facility COVID-19 Module. I have been a nurse epidemiologist with the CDC for 11 years now, and my primary focus is in the role of using CDC and NHSN surveillance to improve outcomes in long-term care facilities. So with that, let's get started. So we have three primary objectives today. We are going to discuss the COVID-19 reporting options for long-term care facilities, including the structure of the NHSN long-term care facility COVID-19 module, review the steps to access the COVID-19 module and the 5 surveillance pathways for data reporting. And then finally, some examples in applying the NHSN criteria to the surveillance data reporting, specifically in that resident impact and facility capacity pathway. As a brief overview for anyone who may be new, I'm going to provide an overview of NHSN and the pathways within the COVID-19 module. So first, we'll look at NHSN, National Healthcare Safety Network. It is a secure internet-based surveillance system managed by the Centers for Disease Control and Prevention. It is the most widely used surveillance system in the U.S. and used by diverse healthcare facilities such as hospitals, outpatient dialysis, surgery centers, and of course our long-term care facilities. The different types of facilities who use NHSN for a variety of reasons, but mainly for the systematic collection and analysis and summarization of healthcare data, such as your healthcare-associated infections, antimicrobial use and resistance, adherence to prevention practices such as gown and glove use, exposures, outcomes, and more. The NHSN long-term care facility component does support the nation's COVID-19 response through the long-term care facility COVID-19 module, which was initially released April 28, 2020. Data reported through this module are immediately available for users as well as for CDC to use in strengthening local, national surveillance, as well as monitoring trends in infection rates, assisting in identifying resource insecurities in these facilities, and informing progress toward infection prevention goals. The module does have distinct reporting options for users, one being the 5 surveillance pathways for data reporting, in which reported incident counts and response data are used to facilitate the assessment of COVID-19 impact in long-term care facilities among the residents as well as the staff. We also have the COVID-19 point of care test reporting tool added to the module in late October of 2020, and this is a platform for facilities to report COVID-19 point of care test results. And then facilities are also able to report COVID-19 vaccinations for residents and staff through NHSN. Facilities eligible to report COVID-19 data into NHSN include skilled nursing facilities and nursing homes, assisted living facilities and residential care facilities, intermediate care facilities for individuals with intellectual disabilities, which is currently labeled in the NHSN application as intermediate and chronic care facilities for the developmentally disabled. I know this is a busy slide, but just to show you, the long-term care facility COVID-19 module does consist of 5 surveillance pathways for data reporting. Collectively, these pathways optimize timely, standardized data collection that is used to strengthen COVID-19 surveillance locally and nationally, in addition to informing ongoing activities to support providers and direct resources. This training will focus specifically on the resident impact and facility capacity pathway. Tips for surveillance pathway data reporting. It is expected that users will consistently collect and report data into the NHSN Long-Term Care Facility COVID-19 module using the most recent data collection forms and instructions on the website. It is very important to have consistent and timely reporting in order to assess the local, state, and national trends, as well as in any response efforts that are needed. At a minimum, data are to be reported for each pathway at least once per week. Unless otherwise stated in the reporting instructions, response to non-count questions are to be reported once per week. Keep in mind when reporting counts, only report new counts since the last time those counts were reported to NHSN. A new count is, again, considered a new occurrence since the last time the same data were collected for reporting into the module. A best practice is to report the counts on the correct date for the reporting week. For example, if a nursing home had 3 deaths during the reporting week, the deaths would be reported on the date in which the death occurred. And this can be done in facilities who report data once per week. Is when you access NHSN, you would just simply go to the correct date on the calendar and report that count for that date. As a reminder, CMS certified facilities must report at least once every 7 days. Data reported to NHSN are transmitted to CMS weekly on Sunday nights, and that is specifically for CMS certified long-term care facilities. It is also important for facilities to maintain awareness of local and state reporting requirements, which may differ from the CMS certified or CMS requirements, or differ from these tips I am sharing with you. So just be aware of those state reporting requirements or your local mandates. Users are strongly encouraged to take advantage of the resources available on the NHSN Long-Term Care Facility COVID-19 Module webpage. This webpage is the best resource for NHSN users reporting data to the COVID-19 module. As shown in this slide, the webpage provides users with access to enrollment information, resources, upcoming and archived trainings, training presentations, recordings, as well as the most updated data collection forms and forms instructions, which you can see are under the data collection forms and form instruction tab. Here is an example of the data collection form and the accompanying instructions for the resident impact and facility capacity pathway, which will be reviewed in detail during this training presentation. Next, we're going to move on to how to access the COVID-19 pathways within the NHSN application and the 2 data reporting options available to facilities. In order to access the NHSN COVID-19 module, an enrolled facility user must log in to NHSN using, must log into NHSN. You may have a SAMS grid card, or if you're using level 1 access. Once you log in through the Secure Access Management Service known as SAMS, the user will be taken to the facility's homepage. Select the COVID-19 tab on the left menu bar as shown in this screen. Once you select the tab, several options will appear. In order to report into one of the 5 pathways, you want to select the daily entry option. I do want to briefly mention a future change to this COVID-19 drop-down menu, in which the option for accessing the 5 surveillance pathways, the name is going to change. I believe it's going to change to daily entry, perhaps, but I just want to make you aware of that so you're not alarmed if you see a different name. But for now, you will select daily entry. And once you do that, the calendar page will open as shown in this right-hand corner here. Here is a screenshot of the calendar that will open. You will notice that the calendar defaults to the current month. Data may be entered up into the present date. Users can also use the arrow icon highlighted to navigate to previous dates. This function will be important if a user wants to enter retrospective data or correct previously entered data. Keep in mind, before entering any retrospective data for a pathway, users should be aware of any updates that have made in the application since that retrospective date, because you're going to want to use the criteria and definitions specific to that time period. So again, the retrospective data entered must align with the correct NHSN version. And we do have an archived version. We do have archived versions of the COVID-19 forms and instructions on the website, and those can be found if you are on the COVID-19 website. On the left navigation bar, there is a tab called Resources by Facility. If you open that tab, right under the tab, you're going to see COVID-19 information. Open that tab, and then you will see a title for archived documents. Okay, from the calendar view screen, users will report their surveillance data for the reporting time period. And there are two options a user may choose for reporting data. The first option I will discuss is importing CSV files. The pathway reporting option allows individual facilities as well as groups and supergroups, such as health departments, to upload data from one or more pathways into the NHSN application using the available CSV templates and upload CSV function. Both are located at the bottom of the calendar view page, which I'm going to show you. A key difference between importing CSV files and manual data entry is that a facility can choose a group or a supergroup to report data on its behalf through bulk upload. Whereas manual data entry is what it is. It requires the user to manually enter the data, the counts, and answer the questions. Which brings me to the second and most common option for reporting COVID-19 data into the NHSN COVID-19 module, and that is manual data entry directly into the NHSN application. So before we get into details of entering and importing data, I do want to point out some additional features. The first being the feature that we have built in to allow facilities to quickly validate if a pathway is complete or incomplete. And this is available regardless of how data are entered into the pathway. And this calendar will update immediately once data are saved or successfully uploaded if imported. So this is a nice feature. You can see in this example here, the resident impact and facility capacity being the first one, and then the therapeutics pathway being the last one on Tuesday the 2nd. Both of those are green. And what that means is that all data, all questions within those pathways have been answered and the pathways have been saved. Or it could mean that the import, the CSV file import for those two pathways was successful and complete. Now the middle kind of yellowish tan highlight of the staff pathway is indicating that the pathway was open and at least one question was answered, but the record was saved as incomplete. So these are nice features that are really for the facilities. NHSN does not look at these features to determine or validate your data, but it is a good way for facilities to quickly validate if a record is complete or incomplete. Okay, So now going back to data submission. From that same calendar view page, scroll to the bottom of the page, and that is where the users may access importing and exporting functionalities. So you can see number one at the bottom is download CSV template. And this allows a user to, or a group user to access the most recent CSV template for the resident impact and facility capacity pathway, as well as the other COVID-19 pathways. Click that tab and it will start the process for downloading the CSV template for you. And then the tab marked number 2 is the process that would be used to upload one or more CSV pathway files to NHSN. Again, one or more pathways may be uploaded during one transaction. So a facility could potentially upload all 5 pathways at one time. And then the last tab on the screen is optional, and this is available to allow the export of data that has been entered into the application, and it will export into a CSV or into a table format for users. Okay, just a couple of considerations. I mentioned earlier that a facility may choose to have a group or a supergroup, such as a health department, report data on its behalf if that group has the capability to collect and export facility level data for its member. There are some important considerations, so two which are considered to be, I would say, most commonly overlooked. Number one is that manually entered and saved data does supersede imported data. And what that means is if a user in a facility manually enters any data in any pathway, it will override data that have been uploaded via CSV file if those submission dates are the same. Similarly, if a facility has entered its own data, it will not be overwritten by a bulk upload by a group or a supergroup. Okay, so that manually entered data trumps everything. And this is actually a good business rule that is in place, because let's say that a supergroup or a group imports data on behalf of the facility, but there is an edit that needs to be made. Instead of having to re-import the correct data, is easier in many cases for the user just to log in, go to that same calendar date as the import, and just edit the imported data and save it. So that function does serve a purpose. The next consideration is that it is recommended that a facility only grant access to one group or supergroup, or at least have an agreement in place, because uploaded data by one group or supergroup via CSV bulk upload can be overwritten if a second group uploads data for that same long-term care facility at a later date. So it's really important that you either have one group uploading data on your behalf, or you have an agreement in place of how that will work, so that data are not being overwritten and incorrect data being sent to CMS. If you are interested in uploading data or more about the import functionality, you will need to work with your vendor directly to provide your NHSN org ID number and establish a process with that vendor. For the sake of time, I am going to move on to the next option for reporting data, which is the manual data entry by a facility user. For those interested in learning more information about importing CSV files, or where to find the CSV file templates, I encourage you again to visit the Long-Term Care Facility COVID-19 Module webpage. And if you open the tab called Resources, click on that plus sign, open that tab, and beneath that, you will see a section called Importing Data Resources. This is where you will find guidance documents, examples of of variables that need to be imported, including importing requirements, variable names, values, format, description, etc., as well as the CSV file templates. We have recognized that there have been some challenges with the most recent NHSN update in February, earlier this month, where the vaccination status questions have been added. We are working through these challenges, and we are planning an open office hours for group users, super groups, vendors to attend so that we can share information with you. So stay tuned, keep a lookout on our website. Once we get those open office hours scheduled, we will send out an email to all users, and it will be posted on our website. And we are anticipating having this meeting, these open office hours, very soon, like potentially this week will be one. So stay tuned for more information about the CSV templates and uploading and importing. Okay, I'm going to switch gears here, and for the remainder of this presentation, we'll be discussing manual data entry, specifically into the resident impact and facility capacity pathway. So remember, this is one of the 5 pathways available in this NHSN COVID-19 module. As previously mentioned, the calendar view page is where a user will begin the process of reporting pathway data into NHSN, either manually or, if you can see at the bottom, via uploading CSV files. To enter data manually, you're going to click on the date for which the data will be entered. So for this example, we are going to use Wednesday, February 3rd as the date for entering data. So you can see here, I would click on that date. Once clicked, a new window will open displaying the 5 tabs representing each COVID-19 module surveillance pathway. Okay, so first one being the resident impact and facility capacity, moving to the staff and personnel impact, moving to the supplies and personal protective equipment, ventilator capacity and supplies, and therapeutics. The resident impact and facility capacity pathway is the default view that will open. This does not mean a user has to begin with this pathway. A user may navigate to any pathway to enter data. However, one caveat I want to mention is that currently facility capacity is a required data element, regardless of any data being entered. So each time a user enters data, you're going to have to click on the resident impact and facility capacity pathway simply to enter the capacity question. And I'm going to show you as we move down the slides, and we will talk more about it. Okay, so let's open this resident impact and facility capacity pathway. This is just a screenshot of what the pathway looks like, and I want to bring your attention to the bottom, save and cancel. These are going to be very important to remember. Once you enter data, you must save the data in order to keep the data. If you hit cancel, it will remove your data for that pathway. The data, as far as saving, you may save incomplete data as long as it doesn't have a red asterisk. A red asterisk means that the data would be required in order to save the pathway. Okay, so let's move on. Again, you're going to want to use the most recent table of instructions when answering the questions in these pathways so that you are interpreting the most recent case definitions and criteria. So the first section is the facility capacity, and it begins with all beds. For this data element, enter the total number of licensed beds in the facility, and this count includes your private as well as non-private beds if applicable. As a convenience, the number entered the first time will auto-populate in all future sessions and should only be updated if there is a change in the total bed count. So for example, if your facility has to bring in additional beds to accommodate overflow of residents. I do want to mention that if your facility migrated from a level 1 to a level 3 access, in other words, you initially only had to enter your name and password, and now you use a SAMS grid card, it is very possible and most likely that the data entered in your level 1 facility did not migrate to this level 3 facility. And what that means is the bed count you entered in the level 1 facility did not migrate to the all beds count in the level 3. Check this next time you go into the application, and if your bed count, if that is blank, you will need to update that bed count. And once you update it once in your level 3 access facility, then it should stay updated for the remainder of the time you enter pathway data. Current census. This data field represents the total number of occupied beds based on the date in which the pathway are being reported. Responses in the pathway are being reported. Again, bringing your attention to the red asterisk next to the current census, meaning this response is required before you are able to save this pathway. This is also required before you are able to save data entered into any other pathway. Let's say that Tuesday, the only data you want to enter for Tuesday are data in your, let's say your therapeutics pathway. Before going to the therapeutics pathway, click on this resident impact and facility capacity pathway, enter the current census for that day. You do not have to click save, just simply enter the current census, and then at the top, go to your therapeutics pathway and open it, enter your data and save. Once you do that, it will save the current census as well as the data entered into that therapeutics pathway. And so that works for each of the additional 4 pathways, and that will save you some time, hopefully. The next data element is admissions. And admissions is used to assess the COVID-19 risk coming into a facility, as well as a facility's capacity to admit residents with COVID-19. The admissions data element represents the count of newly admitted or readmitted residents from another facility who were previously diagnosed with COVID and still considered a transmission risk requiring continued transmission-based precautions at the time of admission or readmission. The count does exclude residents who no longer represent a transmission risk. So that means the count excludes your recovered residents. The count also excludes residents who are preemptively isolated. So for example, the resident is admitted from a hospital and your facility wants to isolate the resident just in case. Those residents are not included in this admissions count, okay? So only those who are known to be a transmission risk are included. Next, we're going to the data element called positive test. The positive test count represents residents newly positive for COVID-19 based on a positive viral test result from either an antigen test or from a nucleic acid amplification test, or a NAT is what I believe you will see on the screen, or PCR. The count is to include a resident newly positive for COVID-19 based on that viral test result, okay? It does include residents who have a newly positive COVID-19 viral test result collected more than 90 days after a previously positive COVID-19 viral test result. So that's considered reinfection, which we're going to get to. But just want to point out that Residents who meet the definition for reinfection are included in your positive test count for the reporting period. Before I move on, again, because we have heard some challenges around positive test, again, I want to emphasize that a positive test is considered a newly positive viral test for COVID-19 is considered reportable in this count if it is from an antigen test or a PCR test, NAT test, okay? The purpose of capturing the positive test count is not to discriminate between false positive and false negative test results. So this means if follow-up viral testing is performed on a resident, such as a confirmatory test, those results are not taken into consideration when reporting counts for positive test. Counts are reported for positive test are not to be changed based on sequel or confirmatory test results. So very important to understand this definition, because counts reported for positive test are the impetus behind subsequent questions that are in this pathway in which we're going to discuss. One being test type. Test type is defined by NHSN as a single or a series of viral testing methods used to detect SARS-CoV-2. The purpose of this data element is to capture testing patterns, such as how newly positive COVID test results are confirmed. Responses to test type are also used to capture inconsistent test results, allowing NHSN to parse out possible false positives before sending the data to CMS. Again, responses to test type are conditionally based on the count reported for positive tests. If the data reported for positive tests, or if the count reported for positive tests is greater than 0, test type becomes a required data element, right? Because you have to identify how the testing method for the newly positive test. Okay, so based on residents included in the positive test count, or the positive test count, you're going to indicate the single or series of viral testing methods performed within 2 calendar days of the newly positive test result. In other words, the specimen collection dates between the newly positive test and any additional subsequent testing must be no more than 2 calendar days apart, with the day of specimen collection equaling day 1. Okay, so any discordant test results among specimens collected more than 2 calendar days apart could represent things such as changes in the viral dynamics, or there could be other reasons, but any specimen collected after those 2 calendar days are not to be considered when selecting viral testing method. Okay, moving on to the next slide. Okay, let's review an example for reporting positive test and how it impacts your test type. So based on this screenshot, and this is fake data, there were 10 residents newly positive for COVID-19 based on a positive viral test. Okay, I don't know, just looking at that row, we don't know if it was PCR, antigen, they were just newly positive viral test results for COVID-19. Based on that 10, we have to identify how those 10 residents were tested. And that is under test type, which is the sub question. Okay, so test type populates into 4 selections for reporting. Again, either the single or series of viral testing methods used to detect SARS-CoV-2 in those 10 residents. Okay, so based on this example, there were 3 residents who, from this positive test count, 3 of those residents had either an antigen test only, they were positive for antigen test only, Or it could be that if they did have follow-up testing, it was outside of that 2-day window, okay? So if it's outside of those 2 days, they are not included in anything other than the initial test. Then we have 2 residents out of that 10 who had a positive PCR test result only. We had 4 residents who had a positive antigen test and a negative follow-up PCR test. And then out of the 10, we had 1 resident with another combination with at least 1 positive. And again, I want to mention here, any other combination would be a combination that does not include a positive antigen and negative PCR. Okay, this is very important. If that combination includes a positive antigen, but the PCRs are negative, that count would go into the 3rd box, positive antigen, negative PCR. And that's very important because of the calculation that NHSN does behind the scenes called calculated total confirmed. And this is an NHSN calculated metric used to identify total confirmed cases of COVID-19 by removing the probable false positive antigen results. So let's look at an example here. You can see here, so we have our 10 positives and we sorted them by test type. And then what NHSN does is takes the 3rd box, which potentially represents false positives because these are cases where there was a positive antigen, but then that PCR was negative. So we subtract those from the positive test count, and that gives us the calculated total confirmed. And that is shared with CMS. And it will also populate on the screen for a user when you're entering those data. If you believe the count to be incorrect, users are not able to edit that calculated total confirmed data field. So if you believe it to be incorrect, what you need to do is go back into the calendar on the calendar date for which the positive test and test types were reported and identify if there are incorrect data that were reported and make edits if needed. And once you do that, the calculated total confirmed will auto update if the corrections are made to the positive test count and or the count reported for positive antigen, negative PCR. Vaccination status is the next data element in the pathway. Again, the impetus for vaccination status is your newly positive viral test results for SARS-CoV-2, okay? So as you can see, there's a pattern here of all these sub-questions based on the response to that one count, the positive test. So currently there are 3 categories for vaccination status. There is the existing field, which is defined as the number of newly residents who tested positive for COVID-19 via the reported test type. So we have the antigen only, PCR only, and other. Those are the 3 test types included for vaccination status. Next, there are the fixed data fields for defining vaccination status. For example, a resident was not vaccinated or did not meet the definition for vaccinated. A resident received 1 dose of the selected vaccine, or the resident received 2 doses of the selected vaccine, and so on. As new vaccines become available, those data fields may change some. For example, there is a new vaccine that I believe is coming out, or maybe already out, that only requires maybe one dose to be received. So the fields under the positive test types will change based on new vaccines becoming available. It is important to note that the count reported represents the number of newly positive COVID-19 residents by test type, okay? So the counts reported in these categories must match the counts that you reported in your test type field. You will notice on the screen that 0 is the default on this screen, and this was done in efforts to minimize some of the data burden when manually entering data. So in essence, a user would only need to change the 0 if you have a count that is greater than 0. In that case, you would replace the 0 with a count. And this unfortunately is not the case if you are importing data, which we will be talking more about in the upcoming office hour calls around importing. Also, just want to point out here that the NHSN definition for vaccinated has recently been updated. So to be considered as vaccinated, the newly positive resident must have at least a 14-day window between the most recent COVID-19 vaccine dose received and the specimen collection date for the newly positive viral test. This added specificity was imperative to allow surveillance for COVID-19 cases that occur after a resident has time to build an immune response. So for more information about that and detailed instructions, please visit the data collection form table of instructions for the resident impact and facility capacity data collection form. And again, that's located on our website. Okay. Here is one example of applying the 14-day window period. This option, again, will be the same for each vaccine type. For the sake of time, I'm going to move on to a more detailed example, but you do have this example in your slides. Okay, so here's an example of how a facility may report for vaccination status. So I'm going to attempt to interpret these data for you. Starting at the top under test type, there were 3 residents reported as testing newly positive for SARS COVID-19 via antigen test only. So then go down to the vaccination status for this test type category. And again, based on those 3 residents, 1 resident either did not receive a vaccine or received the first dose of the COVID-19 vaccine less than 14 days prior to the specimen collection date for that newly positive antigen. Okay, and then 2 residents received both doses of the Moderna vaccine, with the second dose being at least 14 days prior to the specimen collection date for that newly positive viral test. Okay, I hope that's making sense. So let's look at the next test type. Going down to the purple. This facility reported 2 residents were newly positive using PCR, NAT testing only. So then we go down to the vaccination status for those 2 positive residents, and you can see that 1 resident either did not receive COVID-19 vaccination at all, or that first dose was received less than 14 days prior to the specimen collection for that positive PCR, right? Which means that resident may not have had time to build up that immune response to react. And then the second resident received 1 dose of the Pfizer vaccine within the 14 days prior to specimen collection. And it could also mean that the resident received that 1 dose within 14 days, but perhaps that resident received both doses, but the second dose was not within that 14-day window that we're talking about. So that second dose may have been less than 14 days prior to the specimen collection, in which it would not count. And so that resident would be counted as only receiving the first dose. Okay, so hopefully you're getting the hang of this. There are examples, again, in the instructions document to hopefully improve some clarity. Same thing for the other combination. I'm not going to go through that again, but it all applies the same. The final subcategory for positive test is the data element called reinfections. So again, remember, a resident who meets the definition of a reinfection is included in the positive test count for that time period. So when you get to the reinfections, that count is based on those residents included in that positive test count. So essentially, what it's asking you is, based on the residents included in the positive test count for this reporting period, how many of those residents were considered reinfected, meaning they had a positive SARS-CoV-2 viral test result more than 90 days prior to the current specimen collection date. If the answer is 0, put in a 0, that's fine. If the answer is more than 0, let's say the answer is 1. Then you have 2 sub-questions under reinfection. Based on that one reinfection, was that resident symptomatic or asymptomatic during this reinfection period? So during this current reinfection period, did that resident have signs and symptoms of COVID-19, or did the resident just have the positive viral test result but was asymptomatic? We are updating the business rules to auto-populate the 0 if reinfections is reported as 0. We're updating business rules so that symptomatic and asymptomatic will auto-populate based on that number. But for now, we ask that if the answer is 0, that you go ahead and just put a 0 so that your data show as complete. Moving down to total death count. Total death count is defined as new deaths during the reporting period from any calls since the last date total deaths were reported to NHSN. Okay, so any calls, and that includes COVID-19. So any deaths that you have during the reporting period, that count should be included in the total death count. And this does include residents who die in another location, such as a hospital or another long-term care facility, and maybe they were transferred there. As long as that resident is considered a resident for your facility, then you are responsible for reporting any deaths for that resident. The exception would be if the resident was officially discharged from your long-term care facility, meaning that resident is not expected to return and the discharge paperwork was done. So, for example, a resident discharged from a facility to home, you would no longer continue following that resident for death. If you see it in the obituary, it still doesn't get included in your count because you discharged that resident, okay? But unless the resident is fully discharged, the transferring facility is responsible for reporting those deaths. The subcategory for total deaths is COVID-19 deaths. So based on the count of total deaths for this time period, so based on the residents who died during this time period, if any, how many died because of COVID-19 related complications? Okay, so from the total death count reported, how many were related to COVID-19 complications? So your total death count will never be greater than your COVID-19 death count, right? Because your total death count encompasses all deaths, whereas the COVID-19 death count is a subcategory of that total death. Okay, and so I just have an example at the bottom for you. The next section captures resident data for non-COVID-19 respiratory illness. The first data element being influenza. For influenza, include any resident with a newly positive influenza test result since the last time influenza counts were reported to NHSN. This count is based on positive influenza test results. Next, respiratory illness is defined by NHSN as new onset or acute onset of respiratory illness symptoms in the absence of a positive viral test result for influenza and or SARS-CoV-2, COVID-19. This means other viral test results were either negative or not done. Examples may include of respiratory illness may be a new onset of cough or congestion, a new onset of decreased oxygen saturation, a new positive chest x-ray, etc. You count a resident one time for that episode. Okay, so if the resident begins having these symptoms on the Monday of the reporting week, that resident is included in the count for Monday and not again during that week, just one time. For residents with chronic lung or heart disease or other chronic conditions where where respiratory symptoms are maybe a constant, what you're looking for in those residents is something acute, something new, worsening of signs and symptoms, something that triggers an investigation. You know, the doctor needs to look at that resident because something's different, right? So that's what you're looking for in those chronic patient residents. So it could be an increase in the cough in a resident who has emphysema. You're noticing an increase and more productive cough. Or it, you know, same thing with congestion. Their oxygen saturation maybe drop 3% more than what the baseline is for that resident. So you're just looking for something different and new in that resident in order to include the resident in that count. A resident who completely recovers in an episode and no longer has respiratory illness or returns to baseline for those chronic cases. Let's say a month later or 2 months later, the resident becomes sick again and meets this definition. That resident can be included again because we know that a person can have multiple episodes of respiratory illness in a season or in their lifetime. So the resident would be included again, but again, only if the resident does not have a positive COVID-19 or influenza test result. Then we have our influenza and COVID-19 co-infection, defined as a positive viral test result for both influenza and SARS-CoV-2, COVID-19. Since the last time influenza and COVID-19 or the co-infection counts were collected for reporting to NHSN, report the number of residents newly identified as having a positive viral test result for both influenza and SARS-CoV-19. Include the resident in the count only one time. So again, let's use Monday as an example. Monday, you included the resident A in the count. You don't include the resident again Tuesday, Wednesday, Thursday, just that one day during the reporting period. Also want to point out that that resident will also be included in the count for newly positive influenza and newly positive test result for the COVID. So this has to happen because if you remember back, the positive test for COVID-19, that triggers several sub-questions that are important and those data are needed. And that is why a resident included in this co-infection must also be included in those other two counts. So the positive test and the influenza. The analysts know this is happening. And so there's not going to be double counting here, even though it seems like duplicative counting, it's not from an analytical standpoint because those counts will be adjusted. We do allow a 7 calendar day window between the collection date of the positive viral specimens for flu and COVID-19 for them to be considered a co-infection. Here's just an example. So we have 10 positive tests reported, right? And we know that in those 10 positive tests that the one resident that had a co-infection is included in the positive test. And then we have 3 influenza counts for this time period. And we know that one of those counts is also a co-infection. So that one co-infection is included in both the positive test and that influenza count. The next section, the SARS-CoV-2 testing questions, are used to capture COVID-19 viral testing, either performed or ordered for a resident and or facility staff and personnel during a reporting period. So facility staff and personnel include your full-time staff. It can include your contractors and temporary workers as well. A yes response to this first question, since data were last entered into the module, has your facility performed SARS-CoV-2 viral testing? If you answer yes, then the next question are count questions. So you would have to answer how many of those viral tests were performed, and it is categorized by point of care and non-point of care. And again, this is based on since the last date these counts were collected and entered into the module. I do want to specify that reporting in this resident impact and facility capacity pathway is independent from other reporting that is done maybe through the point of care test reporting tool. Okay, those two systems do not talk and they are independent. So if you fail to report this section, then CMS will notify you. So it's very important not to get confused with reporting in the pathway versus reporting requirements in the test tool. So one thing to think about is when you're reporting into the point of care test reporting tool, you're reporting person level data, right? You're reporting resident, staff, person level data, versus in this pathway, you are not. You're only reporting aggregate counts. You're not reporting individual, individual residents or individual staff's data. Then the next questions during the final 2 weeks, what is the average amount of time it took to receive the COVID-19 test results? And again, responses are based on viral test results performed by the long-term care facility, as well as those ordered by the long-term care facility, but performed elsewhere. So for example, a staff member was instructed to have a non-point of care COVID viral test done at a lab. That would be included. How long did it take to receive on average that test result? And then the final two questions assess resource availability over the next 7 days for performing COVID-19 viral testing on all staff and residents if needed. So let's say, for example, there was an outbreak in the facility over the next 7 days. Would your facility have the resources to perform, or would they be able to obtain those resources very quickly to perform testing on all staff and all residents if needed? And that's a yes or no response. And then the final takeaways. I have 2 slides with final takeaways. So I am going to wrap up. You have these slides. They are available on our website. So the takeaway reminders are just a repeat of everything I talked about. I hope that your questions were answered in the Q&A box. If not, please, or during my presentation, if you continue to have questions, please send them to nhsn@cdc.gov and include in the subject line just a brief title, what your question pertains to, especially if it pertains to CSV files, and that allows a more rapid triage of your question so that it can get answered more quickly. And I just want to thank everyone for attending the session today, and enjoy the rest of your day. Thank you.